Yes, welcome again today. We are continuing with diabetes type 1. Diabetes type 1, we left on management of diabetes. Yes, last time we talked about diabetes type 1 and we discussed how diabetes type 1 comes along the pathophysiology and we left on treatment. Management of some types of diabetes is still the same, so I thought we should start on the modes of treatment of diabetes and how we can treat diabetes. We said some complications like DM, they don't have treatment. What we can do is management. As far as I'm concerned, diabetes type 1 is destruction of beta cells. Destruction of beta cells of Iceland of Langerhans cells from the pancreas. So this is a type of management but not treatment. If I'm not loud, please let me know. No one is listening, well, you let me know. So let's remind ourselves about last time topic of diabetes type 1. Because this is, we said type 1 is the Kathleen MTM. Welcome to me today. I'm gloomy today. Okay, I'm cheered up. Okay. We are talking about type 1 diabetes and management, but I'll cover the whole session of anti-hypoglycemic agents. When I'm talking about anti-hypoglycemic agents, I'm talking about drugs that you can use or things you can use too. Yes, it's so gloomy here in Kenya. You see, I'm in a hood. Don't know where you are or how you are. It's so gloomy here. The weather is cold. So when I'm talking about anti-hypoglycemic agents, I'm talking about drugs or things you can use to bring down your sugar levels to the normal levels. A recap of last time, what I want to say is, remember, uh, we are working on management, not treatment. But if it is secondary diabetes to something else, we can work on treatment. Now, we see diabetes type 1 is the destruction of pancreatic beta cells. So, if the cells are not bringing out enough insulin, what do? We replace with something else. Unless we can treat the condition so that the beta cells can be replenished. You remember where the beta cells are? At the islets of Langerhans of the pancreas. Unless we treat and we replenish the cells, we will not have enough insulin. Let's go to anti-hypoglycemic agents, drugs or things we use to bring down insulin. What are these? We'll start by insulin itself. Insulin itself, endogenous and exogenous. Now, insulin can be what you have in your body or what is produced from other ways. Mm? Other insulin production may come from manufactured from some other byproducts like pigs, insulin, several types of insulin that you can use. I'll go through them very fast and then we will discuss about them one by one. As I've said, hypoglycemic agents are drugs used to lower body glucose, mainly in treatment of diabetes mellitus. They can be classified into insulin preparation, oral, non-insulin injectable agents. You see, even non-insulin injectable agents are here. So there are some drugs you can take There are some injection you can get for insulin, and when you take them, they help lower your sugar levels. But we really need to know how they work. So the first class that I will talk about is insulin preparations. Insulin, remember, before I continue, insulin is a protein. I'll explain why I have said that insulin is a protein. Insulin preparations mainly is used in type 1 diabetes. Mostly. Type 1, you remember we said you have beta cell destructions and you're not bringing out enough insulin. So the categories are rapid acting insulin, rapid acting. I know when I'm speaking like that, some people have them and they are using it, and some doctors or some health assistant somewhere doesn't know how to use them. Because when you study, sometimes you can have a problem on how to to decide which kind of preparation to use. So the first acting, it's called rapid acting insulin. One is Lispo, Lispro. We have Aspart and Glucide. These are the ones that when you have a problem, it can bring down your sugar faster. And then we have short acting insulin, regular insulin, that is regular insulin. And then we have intermediate acting, intermediate like NPH insulin. Don't worry, I'll come back to them. Long acting insulin like glargine, Vitamir, and digladute, digladudec. Premixed insulin formulas. You see, in insulin, you can have several types mixed in one. So that it helps a person. For a person that is advanced in diabetes, he can use mixed preparation. Like say you can mix rapid acting insulin like insulin Lispo, and you can mix with intermediate acting, which takes time before it peaks. But the fast acting one will start bringing down as it wears off your body. The intermediate one is picking and taking care of everything. Now we continue. We have other like drugs like oral hypoglycemic agents. The normal one that people know everywhere, it's called metformin. Metformin is called binguanide. Hmm? Binguanide. Binguanide. It reduces hepatic gluconeogenesis. You remember when you were talking about how when you are hungry, you produce insulin from the liver. Now, metformin reduces hepatic gluconeogenesis. It reduces the preparation of glucose from like glycogen to glucose from the liver. Mm? And then the other thing is increases insulin sensitivity. By that, your sugar levels go down. As insulin comes out and you are not producing enough more insulin from the liver, your glucose comes down or your to normal levels. And you know here we're dealing with people that are diabetic. We're not dealing with normal people that have enough insulin. So we have to increase insulin production and reduce glucose production. Now, there are some others. These are drugs that you take. Drugs that you take. We have others like sulfonylureas. Sulfonylureas are gilbeclamide. Gilbeclamide. The normal one that is known is called Nogluc. The normal one that is you understand it's called Nogluc. Nogluc is the normal one. Stimulate pancreatic beta cells to release insulin. These ones they stimulate the beta cells to produce insulin so that it can work on excess sugars that is in the system. And then we have meglitides. Meglitides, glanides, meglitides, glanides. Examples are like ripaglanide, plaglanide, short-acting insulin. These ones are short-acting. They work shortly, but they are so effective. And then we have thiazoladides. Thiazoladides, these ones increase insulin sensitivity again. But you see, these are orals, the drugs you take. They are not injections, they're the drugs you take. We have alpha glucosidase inhibitors like acarbose and maglitons. Mm. They delay the absorption of glucose in the stomach and digestive system so that glucose cannot go up. You get it? So when they alpha glucosidase, these are types of drugs that use. Maybe you have seen someone with a drug called acarbose or maglitol. They delay absorption in the intestine. You see how we deal with these things. You will increase insulin sensitivity, and then glucose comes down. You delay insulin glucose production from the liver. You see, when you delay production of glucose through gluconeogenesis from glucagon from the liver, what happens? Your systemic insulin in the blood becomes normal. You get it? These are people that have problem when it comes to insulin resistance, and you need to bring down insulin. And then we have GLP-1 receptor antagonist. These ones are injectables. They are like semaglutide. Most of these drugs, people use them at home, and they know how they use. Now, so rapid acting like insulin, how do insulin like rapid acting insulin work? Someone might ask you, how do these drugs work? You see, we need to know how they work, and so that we go one on one. Sorry, we go one on one so that we may understand, so that when we go back to treatment or management of type 1 diabetes, everyone knows what to use. Mm? Rapid acting insulin. It works on the onset of 10 to 20 minutes. When someone is injected with this one, it works between 10 to 20 minutes, and it has already started working. You get it? Uh, yes, beauty, welcome. Thanks. I'm cool. Hope you're cool wherever you are. In Kenya right now, it is very cold and rainy. Yes, 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 yes. Welcome, welcome, welcome. Yes. Now we are continuing with the drugs you can use. Now we have started with fast acting insulin. This is rapid acting insulin, which works between 10 to 20 minutes, 1 to 2 hours, peak duration. You see, that is rapid but short duration. It can go up to 5 hours. So let's see, if you give this one insulin to a person in the morning, that is 7, 8, 9, 10, 11, 12. Midday, this person is supposed to be having another jab. Mm. It is supposed to be given immediately before meal. You get it? Because when you start creating some glucose in the stomach and absorbing, it is in your body working. It's rapid on absorption, so be careful to the person that you are giving it. And then we have a short acting insulin. Short acting insulin. Someone is asking where insulin, the manufacture of insulin. Let me see. How are insulin manufactured? Let's see. Insulin. Yes, if you are coming right now, just know we are dealing with how to manage diabetes type 1, but I'm taking through people through what they can use, and how they work on your body. So, um, insulin, let's talk about insulin first. Insulin is extracted and purified from pancreas of pigs or cows. Get it? That is the where you get insulin. It's extracted from pancreas of pigs and cows. Issues limited supply. So that is an immunologic function of manufacturers. They know how to extract insulin from pigs and cows, but in the pancreas, mm, the human insulin gene is identified and synthesized. You get it? Insert in the host cell. Now, that is, we reach there. Let's go back to treatment. I think I've answered that question. So, rapid acting insulin, we have seen it, it works between very short period of time. Let me see. Okay. So, when you take lispo, aspartate, and glucide, that is rapid acting insulin. You expect onset to be 20 minutes, peak to be 1 to 2 hours. Duration, it can go up to 5 hours. And then we have the other one which is called short acting insulin, which is regular insulin. Short acting insulin, remember we are talking about types of insulin that you can use when someone is having type 1 diabetes. So short acting insulin, this one is regular insulin that we use, Humulin that we use. So onset is 30 to 60 minutes, peak hour is 2 to 4 hours. But you see, duration is long. This one can stay up to 8 hours. So it can be used twice a day. This is different from the other insulin that we used before, which is Lispo and aspartate. You get it? This is different. Why? Because the other one duration is 5 hours. This one duration is 6 hours. 6 hours. And then we have another one which is intermediate insulin. Let's see intermediate insulin. So short acting insulin, that one you can use twice a day because it takes 8 hours. You get it? So intermediate insulin, this one can be used at least once a day. Once a day. When I'm talking about days, I'm talking about 12 hours because duration is from 12 to 18 hours. Duration of this insulin is from 12 to 18 hours. We have other insulins like long acting insulin. This one take long. You may go to a doctor and then you are asked to get one jab for like 12, 24 hours. You may be using this one. So most of type 1 diabetes, they use these injections, and you've seen people carrying around those injections wherever they are going. If you are traveling, if you are at home, this is how we do it. You see, long acting insulin, that one can take 20 to 24 hours. So if you are traveling a short distance, there is no need to carry it. But you see, from the beginning, that's how we put them. If you have seen someone with an insulin called Lemevir, this one you give once. But you see, most of the insulin, like long acting, these are given to people that have type 1 diabetes. Type 1 diabetes is what we are giving. And then we have premixed insulin formations. In premixed insulin, this one you can give in this way. You have the rapid acting, and then you add the other one, which is short acting. You get it? So that yes, this one wears off, the other one is continuing in the body. You get it? So this is how these drugs are given, and at times people are confused on how these drugs are given. Now we embark on what we were doing on treatment. A minute. Treatment of type 1 diabetes. Now, type 1 diabetes. Since insulin is the problem here, we will deal with the insulin itself. So, types of insulin used in type 1, because you are not producing any insulin, are the ones that I've just said: rapid acting like Lispro, Aspart, and short acting regular insulin, intermediate acting, and long acting. When you go to a doc, he's the one to decide, because you may have some beta cells that are producing some insulin at a certain level. And this one, it means, let's give like 2 units. A person who is producing 2 units of insulin and can take this person from morning to evening as it works. This person will be given rapid acting Lispo. Rapid acting because it works 3 to 5 hours. But there is a person who has type 1 diabetes and is not producing any insulin. This one needs a long acting insulin so that as it goes up to 24 hours, tomorrow in the evening he injects, as the other dose is wearing off, the other one is carrying along. You see how we take for insulin. I'm talking about insulin because type 1 diabetes, we deal mostly with insulin. Insulin is the most important agent here, because if you give someone, let's say metformin, which acts on, metformin is a binguanide, that is a drug you take. When you give someone who has type 1 diabetes an oral medication like metformin, which is supposed to slow the production of glucose from glycogen in the liver and raise the sensitivity of insulin in the pancreas, what will happen? This person's sugars will go up because this person is not having enough beta cells to produce insulin. So if he's not having enough beta cells to produce insulin, the metformin is not helping, because even if it is causing sensitivity, there is no insulin that the body is producing. So we embark on exogenous insulin that is not from the body, that is the injection, like rapid acting aspartate. But we see if this person is producing some insulin that can take halfway the day after eating, because insulin we deal with units of insulin. Insulin, let's see if I have any injection. There is some, if you look at the needles of insulin, these ones are the needles closely, you will see 10 units, 15 units, 20, 25 units. So we calculate according to how the person is. We see how the sugars are coming up and down, and then we calculate. We will know how many units this person is giving out, so that we know what to reconstitute or to give. You get it? So we continue. We that one I've explained how we give insulin to a person who has rapid acting, short acting, intermediate acting, and long acting. Now we have insulin regimens that we can give, like basal bolus regimen, long acting insulin once a day or twice a day. And then we have rapid acting insulin just before meals. And then we have most psycho, psych, psych, physiologic and flexible. You get it? Where when a person needs it, not regularly. You get it? And then we have insulin pump therapy, continuous subcutaneous insulin infusion. Delivers continuous rapid acting insulin. You get it? This one you have to give continuously. Maybe in a person who is in the hospital. Prefer in motivated patients like children and adolescents. And then we have conventional split regimens, whereby 2 injections of intermediate plus short acting. You see, 2 injections intermediate plus short acting. So insulin dosage. Most you cannot start with a high dose of insulin. You see, this one is a very small syringe, and it's written in units. Insulin can kill a person very fast because of low sugar level. So if you give the whole of this with a person with 10 units of glucose, that person may go. So initial dose you start with is zero point 0.4 to zero point 0.6 units. That is a very small thing, like somewhere here. Look, somewhere here. Yeah, somewhere here. Very small unit here. Just zero point 0.4. Very small number of units. So we don't just give insulin, we calculate on the sugars that this person is producing, and several factors like postprandial fasting sugars, how the person has come out of, has woken up, and the kind of sugar levels this person has in the morning. There is fasting sugars and random sugars. So initial, you start with zero point 0.4 units, and then 50% given as bed as basal. You give the injection 50% divided dose. Now you may adjust as this person progresses. Now there is some factors like monitoring of therapy, um, like the finger stick glucose. You may see these people having some machines that they are always having to check the sugar levels 4 to 6 times daily, because you are not producing insulin, and you need to produce more insulin. And then you have continuous glucose monitoring. Very important. Sensors measure interstitial glucose continuously. This one most of the people don't have at home. Help in fine tune insulin. There is something called HbA1c, glaciated hemoglobin. Someone asked me what is that? HbA1c. Hb means hemoglobin. A1c means sugars. See, this is a marker that shows the, yes, I can see money merger in the platform. Welcome. We are dealing with the management of diabetes. Now, HbA1c is a form of hemoglobin that has glucose molecule irreversible attached to the beta chain of the hemoglobin. Now, hemoglobin is, uh, let me say, red blood cells. Let me show you by a drawing. Particle of red blood cells, Hb. Iron, let me say this is the Hb itself. Hb attached with iron and globin in the center, and the globin in the center. So when you've gone to so bright like that, to say iron, protein plus 4 ions. Yes. So when you go to a hospital and then they tell you, we want to see your HbA1c, what do they mean? They want to know your red blood cell, if it is attached with glucose that is not coming out. Because if it is attached with glucose that cannot be delivered away where it's needed, the HbA1c, the hemoglobin will have a problem of carrying oxygen to be delivered where it is supposed. So that's why it's saying here, HbA1c is a form of hemoglobin that has glucose molecules irreversible attached to the beta chain of the hemoglobin A. It reflects the average blood glucose concentration on the previous 2 to 3 months of lifespan. So when you have high glucose levels in your body, it means even your hemoglobin, your red blood cells, may attach some glucose that cannot be removed. And you see that is a problem. Mm. Glucose in the blood binds to non-enzymatic to hemoglobin glycated reaction. The higher the glucose, the more HbA1c is formed. You see, So the normal ranges here is 5 to 7%, but when you get there and you are given 5.7 to 6, you start knowing you are diabetic. I hope you have understand what HbA1c is the amount of glucose that cannot be detached to your hemoglobin, to your red blood cells, letting your red blood cells impair in function of carrying oxygen and removing CO2. You see, so advantages of fasting blood in the fasting blood sugar checkup when you are type 1 diabetic is very important. It's very important. Why? Because you will know why, where your glucose is before you eat, so that when we can calculate the dosage that you need. If anyone has a question, you can ask as we continue. Now, there are some complications that occur when we are managing person with type 1 diabetes, like hypoglycemia. You see, you may take and you take a excess of the insulin. Or maybe yesterday night you did not eat well and you've woken up, you are used to 6 units, and then you give yourself 6 units. What will happen? Your sugars will go down even up to 1. Hmm? When you find someone sweating a lot and having a problem with vision and is in insulin, the first thing you do, you check blood sugar levels, you will see they are low. They are low. What do you give? You get a sweet, or you get some glucose, you give this person so that some glucose can go. And if this person is a hospital setting, you will be given IV dextrose or IM glucagon, IM. But if it's at home, you don't need to panic a lot if you see the sugars are down. You take something sweet to give this person, mostly glucose from the shops, or something, a sweet that can increase glucose faster. Glucose is absorbed so faster in your mouth. Mm. So if you give within 10 to 15 minutes, this person is not recovering, call an ambulance faster to, to the hospital. And then there are diabetic ketoacidosis. Your sugar levels has gone so high, and you have a lot of glaciated hemoglobin. Now, the fluids that you have in your body are deranged. You have urinated for so long. When the smell that is coming to your mouth is a fruity smell. That is called ketoacidotic smell. Mm. That one is not a person you should be with at home. You take that person to hospital for IV fluids, because now, even if you give insulin at home, this person will get kidney injury because he has no enough fluids. He has acidosis, lactic acid. Ketones are in in the body and they need to be removed by IV fluids. When you take to the hospital, the first fluid this person is given is normal saline, like sodium chloride, so that sodium is a transporter of glucose and it will remove some toxins in the body. So you need to check on that. If you find someone is unconscious at home, you've been dealing with a diabetic and you find this person is unconscious, first do the sugar levels. If they are down, no, it's a complication of the insulin that this person is using. If they are high and is having some fruity smell from the mouth, you don't need to handle that patient. Call an ambulance or take that person to hospital. But if the sugars are down, this person does have fruity smell in the mouth, is very weak, even the vision is down. As you rush to the hospital, give some glucose or let this person have a sweet thing like sugar in the mouth so that glucose can be coming up slowly. Even if they come to normal and the sugar levels have been okay, it's very important you take this person to hospital to determine the cause of hypoglycemia. Hypoglycemia is low sugar levels. Now, we have other things like lifestyle and supportive management. Lifestyle and supportive management. Dietary management. Carbohydrate. People that love carbohydrate. When you are type 1, you should be on diet. Low glycemic agents and carbs. Uh, Lean proteins, healthy fats. This is where problems comes. Avoid excess refined sugars. This is where problem comes because carbohydrate. Some people say they cannot stay without carbohydrate. You can. I've not said you don't eat carbohydrate. You limit yourself to minimal. When you visit a nutritionist, will tell you how you need to take these carbohydrates. Yes, we go to exercise is very important. Mhm. Exercise for a diabetic is important because it increases and improves insulin sensitivity. It increases your insulin sensitivity. Adjust insulin carbohydrate intake to prevent exercise-induced hypoglycemia. You adjust insulin. Yes, Doreen Small, welcome, welcome. We continue with diabetes control. You see, sometimes you can do an exercise and then your beta cells increases insulin. So you may get home from the gym and you feel dizzy and you fall down. You get it. So you need when you are doing gym exercising, you need to check your insulin. You talk to your doctor, uh, adjust the insulin because sometimes some people when they are from working out and they are diabetic and they use the insulin, they become hypo, they lose energy, they become very dizzy. The effect is exercise increases insulin sensitivity. So you may have a problem. So you check on that if you are a person who likes exercise. Patient's education. What I'm doing is the first is what is management. Patient's education. Recognize signs of hypoglycemia and hyperglycemia. That's what we will do right now. And then you insulin injection techniques and sites. Storage of insulin, refrigeration. Some people don't know how to store insulin. And you see this insulin, the problem is some people don't have refrigerators. So insulin may stay for so long and it becomes destroyed and you're still using it. So how do you store it? Let's start with recognizing signs of hypoglycemia and hyperglycemia. Hypoglycemia means low sugar level in your body. We said when we started, blood glucose of less than 70 milligrams per deciliter for American measures, and in Africa and some other states, 3.9 millimole glucose. So, cause of it is excess insulin, missed meals. These are the causes of low sugar levels. And I'm talking to people that have type 1 diabetes. We have not gone to other type of diabetes. Today we are dealing with management of type 1 diabetes. Now, you may use excess insulin and yes, you may use excess insulin and yes, sometimes correct again. Okay. Now, yes, you may have excess insulin and then you may miss a meal. And the other one, strenuous exercise. And you've seen exercises increase the sensitivity of insulin. So as you strain, more insulin is coming out. Alcohol is one thing, and other drugs. So when you are an alcoholic, you are exercising, missed a meal, or excess insulin in your body, you give yourself excess insulin. This may become a problem. Or missed a meal, you may have a problem. So what are the early stages that will show you this person is a diabetic but the sugar levels are down? This is very important. It's very important to note these things. One, sweating, compensation mechanism. Sweating, this person will start sweating, trembling and shaking. Fast heartbeat, because now fast heartbeat is because you need to break down more sugars to give you energy. So the heart will beat fast. Hunger, because you need, your brain has started clicking. You need food. There is no glucose. Hunger, anxiety and irritability, and then you are pale. You are always being pale. Get it? Those are the signs that will show this person has low early. This is, we call them in medicine adrenergic, early early signs, due to sympathetic activation. You remember sympathetic activation? We talked about release of adrenaline, first fear and fright, sympathetic activation. That one we talked about it. And then we have neurological symptoms, neurological from the brain due to brain glucose deprivation. Now, we have, these are due to sympathetic, we have said sweating, trembling, and shakiness, palpitation, hunger, anxiety, and irritability, and then we have pal. But when you go to neurological, the brain will have headache due to there is no enough glucose getting to your brain to help it gain energy. Blurred vision, difficulty in concentrating, confusion, disorientation, drowsiness, slurred speech. Hmm? You can't talk well if you don't have the energy to talk well. Seizures may come at late stage, loss of consciousness and sometimes coma. You see, severe, when it is severe, you may get coma. These are the signs that maybe the person who is a type 1 diabetic, this person did not get the required insulin. He mistakenly did a lot of insulin injection or missed a meal for some day or strenuous exercise or taken alcohol or used certain drugs that may increase insulin sensitivity. You get it? And then we have those who are neurological from the brain. The other ones were sympathetic, activated from automatic nervous system sympathetically. And then we have signs of a person having hyperglycemia, high sugar levels. What are the signs of a person having high sugar levels? Frequent urination. We saw how this frequent urination, go back to the other lesson of diabetes from the start. You will see how a person and the kidney function makes a person to urinate. Excessive thirst. See, if you urinate a lot, it means that you need to take more and more sugars. You need to take more and more, not sugars, fluids, because you are becoming dehydrated. And then we have polydipsia, polyphagia, increased hunger. You need more food. eh? Blood vision. You see, blood vision is in both. That's why I've said when you get someone is unconscious first, and this person is taking insulin, is a type 1 diabetic patient, please, if that person has a gadget to measure sugar, let that be the first thing. Don't start doing things because you may give glucose and maybe you see it is a high. Hmm? Dry mouth, dehydration, always dehydrated. You get it? Weight loss is there, weight loss, and then slow wound healing. Because now, we talked about high sugar levels and wound healing. You get it? High sugar levels in in your system is related to bacteria that are high colony in your body. So the wound will not heal. Heals very slowly. So take care not to get wounds or cuts every time. Now, when it is severe hyperglycemia, it may lead to this. When it is very high sugars, diabetic ketoacidosis, we talked about it, nausea and vomiting, abdominal pain, the fruity smell from your mouth, the sweet breath odor from your mouth, breathing rapidly. We call it Kussmaul breathing, breathing rapidly. Confusion and coma because of high sugar levels, even exceeding the brain gets impaired. We call it encephalopathy. Hyperosmolar hyperglycemic state. Now, this one is more common in type 2 diabetes, but even type 1 they get extreme dehydration, severe weakness, and neurological changes. Now, let's compare because we are managing these things. We are managing hyper and hypo. This is a person who is using insulin, is a type 1. You compare in onset, how does it rapid? Hypoglycemia, onset is rapid. The symptoms come faster. But in hyper, the symptoms come slowly. The headache comes slowly, dizziness comes, but in hypo, it comes rapidly. Hmm? Okay, we continue. Key symptoms. We continue. We have key symptoms in hypoglycemia. This sweating, tremors, palpitation, confusion, and seizure. You see, sweating, tremors, palpitation, confusion, and seizures. But in hyper, when sugars are high, thirst, frequent urination, hunger, fatigue, and blurred vision. So in hypo, sweating, tremor, palpitation, and confusion, and seizure. But there we have urination, hunger, fatigue, and blurred vision. And then we have in severe danger, seizures, coma, and death. This is in hypo. Now, in hyperglycemia, we have diabetic ketoacidosis and a hyperosmolar state of high sugars. Now, immediate action in fasting is giving glucose if it is low. But in hyper, check blood glucose and give insulin. Hydrate always. Now, today, I don't know if anyone has any question. It was a very short video on management. I think it is very cold and I'm required everywhere. That's why you see I'm being consulted here every time. So I don't know if anyone has any question. So that tomorrow we may start with the other type of diabetes type 2 or diabetes mellitus. Today we were just dealing with management of diabetes type 1. So if there is no any question, thanks a lot for being coming on the platform. It was a short session of today. I'm needed somewhere. It's a very busy day. Enjoy your day and be blessed, everyone.